This podcast is for educational purposes only. Please consult your doctor before changing any medical care. This information, products, or comments contained within this podcast is not approved by the FDA for the treatment or diagnosis of any disease. Although we attempt to keep the information up to date and current, we cannot guarantee the information is up to date at the time of this recording. Individual results will vary. No one should expect the outcomes or results mentioned or described in this podcast. Health shares do not constitute health insurance and do not provide a guarantee to pay for your medical bills. Please consult your broker, general counsel, and/or doctor before changing your healthcare plan. Envita and Envita Health makes no guarantees for outcomes and results. For joining us, I'm Dr. Dino Prato, founder and CEO of Envita Medical Centers, with one of our chief medical directors and also works on our research team, Dr. John Oertle, as he's part of the treatment medical team. I'm on the R&D administrative side of the group. And here we have a 67-year-old female with metastatic ovarian cancer. And again, I know you may be watching some of these. We're trying our best to give everybody an understanding and how powerful precision oncology is and how the details matter and the before and afters matter, because that's the goal, is getting our patients well. And so, Dr. Oertle, welcome, and go ahead and take us through this case, and I'll jump in and ask questions and, along the way, and point some things out as well.
Yeah, thanks, Dino. Appreciate it. Well, yeah, this was like you said, a 67-year-old female who presented. This was a recurrent metastatic ovarian cancer, which she had originally been diagnosed with ovarian cancer. She had a full hysterectomy, but she elected to be able to do no chemotherapy. She didn't want to be able to do it. She researched and just saw the side effects of high dose chemotherapy and refused to be able to move in that direction. Now, before she came to us, she also pursued the natural route and wanted to be able to do something. I respect and all patients' recommendations. I wish I would have seen this patient earlier, because there would have been more that we could have done even back then when she had originally gotten that first diagnosis.
So let's point this out for a minute, because over the years you get patients who they instinctually don't like chemotherapy because, number one, they're scared of it because they've seen a family member maybe pass away or have horrible side effects, rightfully so. What Envita does is so much more milder and targeted. You really oftentimes avoid many of those harmful effects. But she goes the natural medicine route. And I bring this out. We have a lot of colleagues in the integrative medical space. There's just no precision. Again, it's just, let's try this vitamin, this high dose vitamin C, or let's try this herb, and let's try good stuff, but it's not, there's no precision, right? There's no precision targeting to it. And so
many times it's tolerated better, but it's not, because of no precision, it doesn't actually show better outcomes, but it's tolerated better. And this is where there's a benefit to doing, and one, always making sure that you're making good decisions based upon the individual's data that's coming out for them, and not just a shotgun approach. And then two, really being able to make sure that you're using the best options that are currently available to ensure that you're working with the conventional, with chemotherapy. If chemotherapy is a good option, that you're dosing it correct, that the way you're administering it is the best. And then you're also pairing that with the integrative that can be actually very powerful to be able to enhance the action.
So this is what I would tell patients, because we've done it all. We've been here for 23 years, and probably one of the leaders, there's probably maybe others, but one of the leaders in the country in integrative medicine for oncology for sure. And I would say precision matters. We have found in our many thousands of patients over the years that precision, whether it's the natural and or the conventional, sometimes you need a little bit of both, speaking from what we've seen. That's where patients get these wonderful experiences, like we're going to see here. Great before and after picture. So this is a metastatic ovarian cancer. Let me just move along. So here were the markers that, go ahead.
Very high tumor markers. Now, many times, again, people aren't aware of HE4, which is it's a marker that's specifically elevated, that can be elevated in ovarian cancer. I always say, again, not all oncologists I've seen are running HE4 for ovarian cancer. So please, if you have ovarian cancer or a family member, please get them to run HE4, because again, it should be a conventional biomarker and cancer marker that you can run for ovarian cancer, but I've seen that not all oncologists run it.
Well,
But this woman that came to see us, her HE4 was very high, and her CA 125, which is very standard in the industry of ovarian cancer, that gets run in conventional oncology, was also elevated as well, 64.8, very high.
and this is the CA 125 more common. Everybody's more aware of that. The HE 4 less, but needs to be run. But let's go to the category that almost nobody runs, and here's the genetics. This tells us the mutation of the individual patient, which, that's one of the big advantages. So we'll go through this because it shows you the genetic mutations that are playing a role in the driver of this particular person's cancer. Remember, two people with this, I've been saying this, you might go back and watch some of my old videos on YouTube stuff that go back probably, a decade or longer. And I'm saying no cancer is alike, and I'm talking about this before it's even a thing. And it tells you we've evolved way beyond all of that today to a much more, even more modern, more detailed immunotherapy and genomic profiling in our algorithms. But I just want to share that I can tell you when anybody, outside groups, oncologists, the media, anybody tells you that precision oncology is not a thing and it's not something that is standard, I would run and not walk, because at the end of the day, the results are what count, people's results. So, John, go ahead, Dr. Oertle, take us through these mutations and what was found in this patient.
Yeah, so we're seeing, again, we're running a couple of different things on this slide that we're actually focusing on. We're seeing the total mutational burden, which was really elevated in this actual individual at 19 mutations. That's
at the top, just so people can follow. When you see this total mutation burden, that means these are the total amounts that are leading to the mutation shifting of the cancer, making it more resistant to treatment. And then as you go all the way down, you'll start to see specific markers to the left, and you'll see percentages, because later on you're going to see in the slide how these clear up, and they're very important indicators in treating the patient. So we just want you to be able to track that. So go ahead.
Yeah, and it's giving you both prognosis, because when those are elevated, it's poor prognosis. But when we treat it and they come down, it's a leading indicator, and we run this on a regular basis, because when those come down, we love celebrating that with our patients, and I want to be able to make sure that our patients understand that when those come down, it leads to it's a better prognosis when those decrease. What's also interesting, I'll point out on this slide here, because we actually, a big part of this was our immunotherapy, as it is with a lot of our patients that we actually treat, but it's microsatellite status. I've seen oncologists say, well, if MSI is high and not detected, then why are you giving immunotherapy? And I always say, I've seen this, right? And this is one of these areas that they say this, because when you have an elevated or a MSA detected cancer, that you see that it's approved, FDA's approved immunotherapy and PD-1s, just a fraction. That's just one part of immunotherapy for MSI detected cancers. Again, that's
so let's take a minute here. MSI, high microsatellite instability, right? Give a little bit of, so we know that that's a new, not too far long ago, they included that as a standard to do immunotherapy, but there are many other factors. And I bring that up because you will get these people come in and say, oh, it's in the literature. Yeah, where were they in 2015 and 14 when we were using these things on and off label? We have so much experience. I don't want to say this in a negative way, where it's really nice to hear your opinion in conventional oncology, but oftentimes you just don't have the breadth of immunotherapy or the tool belt, so to speak, to really go after a lot of these cancers. No offense. I mean, your tool belt is limited to what insurance is covering, what the standard of care is, and maybe just to a PD-1 inhibitor, which in itself can be very limiting. But I want you to spend a little bit of time, because this is about getting patients well. This is not about, doctors having their arguments of when you give this or when you don't give that. The bottom line is the outcome, and the outcome is what matters. So, Dr. Oertle, talk a little bit about that and some of the issues with that MSI is the driver, that microsatellite.
Yeah, okay, well, let me share this with you, because FDA approves chemotherapies and cancer treatment options based upon tissue. And so if you have ovarian cancer, for instance, again, what we're talking about today, that it has been, and it's been their model, that it's based upon, if you have this ovarian cancer, then you get this approving of this chemotherapeutic regimen or this drug that actually treats ovarian cancer. But what we see is that FDA is slowly, finally starting to be able to actually transition to a precision model. And yet, so we've been doing precision for so long, and this is where it's not based upon the tissue of ovarian cancer. It's what kind of ovarian cancer do you have with all the mutations that go along with it. FDA has finally started to be able to move, and it's not even a lot of drugs that are actually approved for this. But I only speak out of that into that because MSI, if you have a biomarker that has microsatellite instability that is actually present, then what you actually find is that you can be approved for various immunotherapies, or Keytruda, Opdivo, or the PD-1s. My point is that's even a fraction. And I've seen individuals that it doesn't work all the time. And there still is, even with an MSI mutation, at least it's approved. So your insurance will cover it. Your oncologist may actually recommend it because it has been approved as far as this goes. And you can have any cancer with that MSI biomarker, and you will be approved for that. Now, that's still just a limited fraction, and there still is hurdles to be able to make sure that those outcomes are being fully received. But this is where, for my point, is that you do not have to have MSI, but there's other markers. One of those markers is just how much tumor burden you have. Now, I said tumor burden is a bad prognosis because you don't want to have a lot of tumor burden in the actual body, the mutational burden. But the interesting thing is it's a bit of a silver lining, Dr. Prato, because when you have an elevated tumor burden, it actually means that there's a higher likelihood that you will respond to immunotherapy because your body already, those mutations are such a mutated rate that they already are showing that they're not a normal cell within the body. So the immune system has a better time finding that and picking it up. So then the question becomes, what's going on with the immune system as far as why are they not seeing those mutations as diseased cancer? And so we work on helping the immune system to be able to actually recognize and be able to be built to be able to actually treat the cancer.
Here you see, the mutational burden at 19. Below, you see all these mutational percentages. This person has a lot of mutation going on, in itself an indicator of immunotherapy. Now, one of the interesting things is to bring up is that FDA doesn't treat patients. I mean, they do their safety and trying to do one drug. They don't, right? And yet most of what goes on in oncology today is based on insurance billing, what's allowed, and then, that's standard, and they're operating in the standard. But in this population base, they would have missed it. And this poor, woman would have not been alive, right? Had she not, because in the conventional model, this is even though the patient didn't want chemotherapy, you are usually not going to see those chemotherapy selections, which we'll show here in a moment, wouldn't have driven the same outcomes. They may have slowed things down with a rebound effect on the back end, but you don't see it resolving this type of disease. So let me move along here. Let's look at the actual imaging.
I was gonna share, we've seen patients and family members who have actually been who have worked for FDA, who have been patients of Envita. So, quite the contrary. And it's just, it's very interesting because you make a good point that FDA does not treat patients, and the patients can't wait for FDA to find and for conventional oncology to catch up
or
with
insurance
technology
companies
that's able to be available today. That is all under we practice, all per federal and state regulations, and we cross our T's and dot our I's to be able to make sure everything is in compliance. But this is where it is not conventional. It is a unique perspective that Envita deploys, all based upon our each individual licenses to be able to actually administer the kind of care that we do.
Yeah, and I think what's important is the outcomes and that the targets are right and the data is there. And you can't wait for your insurance companies because they're the last ones to cover anything. So this is the brokenness of healthcare, insurance, and of the medical system. But this patient, as we continue here, you can see the imaging And you can see this, so, this cancer all through the abdomen here, riddled all through the body here, that's lit up like white. You can see it very clear here in this image. So go ahead, Dr. Oertle, if you want to go into anything more regarding this image.
Yeah, what you'll see is that the cancer is a very large cancer tumors that are in the abdomen and littered all throughout the abdomen. What you'll see, that bright area that the lowest or the most inferior white dot
So
there.
not all. So
That's
at the
bladder
lowest, right down in the midline where you see the urinary area, right? That's the collection usually of the
of the contrast
material
material.
of the contrast.
That's the
But
contrast.
anything above it, where you see this very large ball right above it, and then another ball above it. So as you're looking and onto your right side, this is all cancer. So
And
you
what
can
you'll
see
see
it.
up there, you'll see the very top. That's the brain to give you
Yeah.
kind of an orientation to that.
Let's
But
move
all
on because we're
the
going to look
areas
at.
of cancer in the abdomen.
Yeah, we're going to see the before and afters here. So here's just telling us all the
And you'll
things
see,
we
I
just
mean,
saw.
this gives you a characterization as far as how big these are. I mean, this is 3.6 by 3.1. This is a 6.1 by 3.1
Yeah, these
centimeters.
are large
These are
tumors.
large tumors in the actual abdomen, all throughout
Let's
the
move
abdomen.
on. So these are all the things we saw before she began treatment with our team.
Okay,
This was the
so now
treatment
we
plan.
begin treatment, and we prescribed a 12-week plan with this individual. We gave her our GTF chemotherapy. That's our genetically targeted fractionated chemotherapy. So every reason why she avoided standard high dose chemotherapy, she desired to be able to actually do the care because we focus on outcomes. We do what's best, and this is where
And let me just lay this out. Once we have the detailed markers, we don't give large doses of chemotherapy. We
correct.
can use a gentler approach because any patients, we've had patients do treatment and they're hiking Camelback Mountain, they're exercising. They don't look like cancer patients. They don't have the same worry of chemotherapy because when you have the right targets, you don't need to blast the body with these very high doses, which can cause more resistance, weakening of the immune system, losing of your hair, all the side effects. You can get treatment, tolerate it very well, and literally get stronger every day because you have the integrative care to encourage you. That's why people like GTFC, genetically targeted fractionated chemotherapy. And then we also use metabolic markers in there to help guide depending on what we're targeting. But that makes a huge difference. And in my opinion, I've said this before, maximum therapeutic dose, where you blast the body with this chemotherapy right out of a textbook, is what oncology does. And it's a mistake. When you have the right targets, you can give, a much lower dose with a lot less side effects. And the doctor will look at that and say, well, this isn't effective. This is only 15% or 20%. Yeah, but look at the outcomes. What do you mean it isn't effective? According to who? What's your clinical experience? I don't mean that in a negative way, but we've been doing this for 23 years. And when you have the right targets, you do not need to hit the body very hard because it responds very well. And when you do CIPI, chemo immunoprecision injections, you go right to the tumor with a catheter the size of your hair. And you come out with a Band-Aid right to the tumor with the genetic targets. You eliminate all of this need to pour. When you give IV chemo, it's like 4 or 5% that even gets to the tumor. It's very little. And if you don't use any metabolic targeting, we can up that quite a bit with our GTFC, but it goes everywhere. It doesn't get to where it needs to go. And with CIPI, right, with the chemo immunoprecision injection that we do in Envita, it goes right to the tumor. You're getting 100% at the tumor where you want it, not all over the body. So you don't get all of the same type of adverse events and side effects that people, when they hear the word cancer, they're terrified. Oh my goodness, I have to go through all this treatment. That's really what I believe was going through this patient's mind. And I don't blame her because she wanted precision, targeted. They didn't want all those side effects. Let me move
Yeah,
along here.
you also can I share this as well? When you get high dose, maximum therapeutic dose chemotherapy, it doesn't just create side effects. One of the side effects that it does create is a suppression of immune system.
Yeah.
That most chemotherapies are going to suppress immunity. And again, when it comes to cancer, most cancers, the immune system is what creates long-term remission. Long-term
So
remission.
if you're wiping out the immune system, okay, which you're doing with this high dose untargeted chemo that's in the conventional model, you're actually setting up their body to be open to more infections, more spread of disease, more resistance, because the immune system has to be in place and intact. I mean, this is almost opposite, right? I mean, I don't want to offend everybody in that model, but it's opposite to just pour chemo in, weak immunity, lower white blood cell counts, anemia. They have all these side effects and issues, and the patient is not stronger afterwards. It's what I call outdated and archaic. That's my opinion. I've been around this field for a lot of years,
Well,
and I
this is
just
one. Well, this is one of the reasons that you do see oncologists excited about immunotherapy. When you have the Keytruda and Opdivo and the PD-1s come out, they're very excited, but that's still just a fraction of immunotherapy. Now, we
yeah,
did give PD-L1 inhibitor. We gave a PD-L1 inhibitor to this individual because, again, it was appropriate in her case, but it wasn't just that alone because it's important that it only had that.
so let me just say this: is it fair to say that wouldn't have done the job? And
It
that's the
likely
bottom
would
line.
not have done the
I
job.
mean, in the conventional oncology, you may have even gotten that, but it wouldn't have done the job because it's too little, too late. And we know because of years of using
What
these
we
for
do.
decades.
Yeah.
Yeah. So we can tell you that people put all this weight on these PD-1, PD-L1. They're the new thing. They're great. But if you don't understand the full comprehensive immunotherapy approach, it's not as wonderful and miraculous as one would want it to be, right? And it's important to say that. That's why we offer a comprehensive immunotherapy approach. Okay, let's continue
Now, what
here.
you'll also see, real
Okay,
quick, go back because
go.
we also recommend a PARP inhibitor. And with a
Okay.
PARP inhibitor, this is on label for ovarian cancer. But again, her specific breast cancer or ovarian cancer had targets to show that it was helpful. And also, what's really interesting about PARP inhibitors is that they actually have an immunotherapy benefit. So they actually work together synergistically with the immune system, not just a high dose chemotherapeutic action that's going to suppress immunotherapy.
So
See,
why?
it's
So
integrative medicine. It's combining to be able to make sure that there's synergistic effects with the therapies that we
So
give.
one of the important things we do at Envita in our design is making sure that all the therapies are working in concert with each other in the
Correct.
algorithm. But immunotherapy is really the star of the show because we learned a long time ago that strong immunity, your cancers, you develop 10,000 cancer cells in your body every day or something, and I've talked about this for years, and yet a good immune system eliminates them. So when you help the immune system recognize the cancer, it changes the game. It changes the outcome. It improves significantly. That's where we're seeing the great improvement, and it's more than just a PD-1 inhibitor. You have to understand the immunotherapy. Alongside, there were some oral smart drugs. There were other supportive integrative agents, IV therapies
That's right.
that were
That's
they're
right.
very very powerful natural integrative agents, which we don't always talk about, but they play a huge role in changing the environment. I mean, cancers need oxygen. They do very bad. They're very into fermentation versus using energy from oxygen. We metabolically shift that. We work towards going at the root of the cancer. This is all happening. We always talk about it. We're focusing on these targets, but this is all happening at the root of Envita's care to shift the body's environment so that it's all those things that people starting to hear. Oh yeah, low oxygen is a hallmark. The Warburg effect. We've been doing that for 23 years. Nothing new to us. It's great that you saw it on YouTube last week, but we've been doing this for 23 years. And the metabolic function of your body is critical to shutting down the susceptibility of cancer growing, right? Because it needs certain hallmarks. So we'll move along here. Right? All right. So here you can
Okay, so
see.
this is the conventional tumor markers. This is a little bit of a confusing slide because the actual timeline here, instead of going left to right, this chart, the way that it's been demonstrated, goes right to left. So on the right is when the patient first came on in, and we track and monitor those. But what you'll see is that there's been a beautiful, nice continued trend in a downward fashion from when the patient first arrived to when the patient left. And what you'll see here too is that there can be oftentimes, real quick, go back, there can be a little bit of a spike. And this is where tumor markers can elevate as a result of treatment. So what you actually can see with the actual tumor markers is that when there's a lot of die-off, you'll see that this tumor marker dropped really nicely, but there was a little bit of a spike. And what you can sometimes see with this is that when there's more die-off of the actual cancer, you can see a rise in those actual tumor markers. So let's keep going.
And then here you'll
And this
see
is your
the other.
conventional. This is what every oncologist runs for ovarian cancer, your CA 125. And what you can see here is look at this beautiful from on the right. You see when the patient first arrived, very high at 64.8. And what you see is that it's just this beautiful trend all the way down. And it's now in a completely normal range at 10.8. Very
So
beautiful.
let's take a look here at the genetics as we're testing them along the way. Look at the percentages of
So
these
here's
markers.
so here's a snapshot. What I said as far as look at that very top marker as far as the blood tumor mutational burden went from 19, and then the very next time we ran it after our treatment, it had gone to 0. What we see with a lot of these other tumor fractionations is that they weren't ever detected anymore. And what you see is that they all dropped significantly, and then 2 of them were only present in very small amounts. And
So this
so
is
this is
important
a
because,
very good
and
prognosis.
you won't usually get this run, at least today in your standard oncology world. And what you have to understand that these are the leading indicators. This is telling you that mutation is shutting down, the cancer is dying, and the body's immune system is getting back into control here. I mean, that's for the layperson to see that, is that the immune system is at work, and so is the chemo targets as well. And you can see these are those same genetic mutational markers, but on a colorful graph, you can see them all dropping. They're all dropping down.
Yeah, and the importance to this is even if you're one of the lucky ones that you can convince your oncologist to be able to run it for you, at least initially, we run it consecutively because cancer is a disease of mutations, and that you can see mutations change. You can see cancer mutations change or shift, and this gives you not just the information. Go back and well, you can see this here on this slide is that as you see, we're seeing nothing but trending down. What does this tell me? Is that the patient all throughout the course, and I trust this even over the tumor markers because this is, as you say, a leading indicator. This is showing that we are shutting down that cancer messaging and those mutations all throughout the course of treatment. And then this is where, if you ever were to see, this doesn't happen with everybody, but it's important that it's being ran consecutively because let me just tell you this is that if you see those mutations change or shift, then it means that treatment may need to shift right along with it because it's never just, it doesn't happen that it's just, you get the same treatment and then 3 months down the road, you're all the same treatment. You need to continually monitor that to be able to make
Let
sure
me
that
explain
it's not
that
mutating on you.
Let me explain that in a way a patient can understand. Normally, when you run imaging every 3 months or they do a PET scan or whatever, by that time, you have lost valuable time and information. That valuable time is so precious. That's why leading indicators like these genetics that we run and the CTCs, and then us being able to use our algorithms to tie into them to make the right modifications so that our patients have the best chance of responding makes the world of difference. So let's move along here because an image is worth 1,000 words, as we always say. And here's the beginning and the end. So you can see to the left, all of those abdominal masses are gone. What you're seeing to the right is just the 2 areas of the contrast coming out of the kidneys and the bladder. But for the most part, the rest of the lesions, the abdominal lesions there are clear and they are resolving, and they are those large centimeter tumors have completely shrunk and gone away. This again is a patient. Now, if we go all the way back just for a minute, I just want to give people a little bit of understanding. So you have a patient that comes to you with metastatic ovarian cancer that is in late stage. The patient has all of this tumor spreading throughout their body, right? All these tests are run to target the treatment correctly, and then this is the results you got. So this is what happens with it's so exciting. This is good, real hope in the essence that this is where cancer is going. You take a disease that's late stage, it becomes treatable, manageable. I mean, the quality of life, the outcome here, this is exactly what we want for every patient, for every loved one, for anyone, that this disease is not scary anymore. It's treatable, manageable disease. And I'm going to let you,
I
John,
love
Dr.
this because
Go ahead
the
and go over some of
radiologist said when reading this film, resolution of the FDG activity in the abdominal small tissue compatible with complete metabolic response to therapy. resolution or significant decrease in size of abdominal mass is compatible with complete to near complete anatomical response to therapy. No evidence of abnormal glycolytic activity. I love this. It's just,
So
this
you
is
can see
where,
it. You
this
can see
is
it.
the reason, this is response. This is where, when your immune system is doing what it needs to do, this is what you see. And how beautiful is this? That, because at the end of the day, this is where it's easy to be able to talk about cases. But Dino, what I love about why we do what we do is because this is a patient that we love. This is a person on the other side who was fearful of looking for options because she didn't like the options that she was seeing and being recommended. And I completely understand that, and her family members. And now we get to be able to actually, this is not just an image on a page or on a screen. This is a person whose life has been impacted and changed, and is now, again, who's appreciating the life that she has to be able to spend with her family. And that's is
And
a
this
great
is what
way
we
to
can do. We can do this for so many patients. Obviously, we can't guarantee everybody's outcomes, but the sooner we get a patient, the sooner we're able to put this technology to work and put the odds and the technology in their favor. And what I love about it is, when you look at the end of the day, you have we were looking here at the
Well,
before and after.
this is great too. One, go back. That's the last update too. This was the CT scan that was performed in February. So that was performed in December. She got to go home and be with her family for Christmas as well and enjoy that Christmas. And look at this. This was in February. Again, nothing for tumor reoccurrence. She's home and she's celebrating her life and being able to actually be present without any additional.
Now, I do.
No more tumor mutations. No more tumor mutations in the actual genetics, and there is absolutely zero evidence of disease on imaging. This is
Well,
beautiful.
you can see it right here. Well, listen, this is another great case, and we're just going to keep bringing them to you because we have a bunch of these, and we do our best to get them to you. And Dr. Lee, again, I thank you for joining me today and going over this case. And again, I welcome all of you. Anybody watching has any questions about their cancer, needs any help, we're here to help you. Reach out. I mean, we may have the right pieces of the puzzle for you that might help you. Our team is here to support you. And may the Lord bless you on your journey to healing, give you the guidance and the tools you need to help you live a long and blessed life. And Dr. Oertle, thank you for joining us. And we thank you all for spending time with us again today, going through another case. Thank you.